Hello, this is Malcolm Galloway. I'm a neuropathologist, and this is a case-based video tutorial related to muscle pathology. As we go through, I'll ask some questions and some musical play to tell you that that's some time to think. If you want more time, just pause when the music's playing, and then when the music stops, I'll give you the answer. This case we're going to discuss is of a 65-year-old man who had a gradual onset of weakness affecting his fingers and quadriceps. He also had dysphagia. His creatinine kinase was only mildly raised. Muscle biopsy showed a mild variation in fibre size, moderate endomysial chronic inflammatory infiltrate, the endomysium being the connective tissue between the muscle fibres, and scattered necrotic fibres infiltrated by macrophages. There were also occasional fibres which appeared otherwise viable, which were infiltrated by CD8 positive T cells. Many fibres contained these structures, which are a characteristic finding in this condition. So the first question in this tutorial is, what are these structures called? These structures are called rimmed vacuoles. On hematoxylin is in stained sections. These vacuoles are rimmed by bluish granular material. On trichrome staining, this material looks more red. Stains for amyloid, such as Congo red, will label these structures. So the second question is, which condition is this patient most likely to have? This patient has inclusion body myositis. This is a sporadic disease which is relatively common in the older population, predominantly seen in the over 50s. It's more common in men than women. Typically affects both proximal and distal muscles and can be associated with dysphagia. The serum creatinine kinase may only be mildly raised, if at all, although it can be raised up to about 10 times normal. Muscle biopsy typically shows some variation in fibre size, infiltration of the endomysium by chronic inflammatory cells, some necrotic fibres infiltrated by macrophages, some otherwise intact fibres infiltrated by CD8 positive lymphocytes, and these characteristic rimmed vacuoles. It is a slowly progressive condition which unfortunately doesn't respond to a specific medical treatment. For example, immunosuppression is ineffective in these patients, although there is an important role for supportive therapies, including physiotherapy and occupational therapy. Due to its slowly progressive nature, this is a disease which could be easy to misdiagnose or to underestimate the significance of. And I think at an undergraduate level, it's important that students are aware of the condition. For postgraduate trainees in neuropathology, clinical neurosciences, or enthusiastic general pathology trainees, there's a supplementary question. Can you name any other conditions which are associated with rimmed vacuoles but are not inclusion body myositis. It's important to be aware that rimmed vacuoles are seen in other conditions, not just in inclusion body myositis. And it's also important to be aware that they may be not seen in a biopsy from a patient who actually does have inclusion body myositis, as often is found in muscle pathology. The pathological morphology can be very patchy, and if a muscle biopsy fails to include the cells which have the rimmed vacuoles, it may not be possible to make the diagnosis. Sometimes patients have a second biopsy which then shows the rimmed vacuoles, or sometimes the clinician will assume the patient has inclusion body myositis on the basis of an absence of another specific disorder in the biopsy and a clinical presentation typical of inclusion body myositis. There are several inherited disorders with prominent rimmed vacuoles. Typically, these conditions are thought of as inclusion body myopathies as opposed to inclusion body myositis, in that they aren't associated with inflammation. There is a hereditary formed inclusion body myopathy with sparing of the quadriceps, which is in contrast to the prominent involvement of the quadriceps in inclusion body myositis. This condition is due to a defect in an enzyme involved in the synthesis of sialic acid. There are several other hereditary myopathies with prominent rimmed vacuoles. Rimmed vacuoles may also be seen in neurogenic conditions and in limb-girdle muscular dystrophies, although these tend to be much more sparse than in inclusion body myositis. The finding of morphologically identical rimmed vacuoles in a wide range of conditions suggests that there may be a final common pathway of a degenerative process rather than being the cause of the disease itself. It should be acknowledged that inclusion body myositis is a very controversial entity etiologically. It's still unclear whether it is primarily a degenerative disorder or an inflammatory disorder. It could be that the inflammation is secondary to the degeneration, or that the degeneration is secondary to the inflammation. This is still very unclear. So to summarise, I would hope that for those at an undergraduate medical level, you will have your familiarity with the condition of inclusion body myositis enhanced, and that you will consider the diagnosis in older patients developing slowly progressive weakness. For the postgraduate trainees, I hope to have highlighted the fact that rimmed vacuoles do not in themselves mean a definite diagnosis of inclusion body myositis, and that there are a variety of other conditions which may have rimmed vacuoles. As always with muscle pathology, close correlation with the clinical findings is essential to avoid misdiagnoses. Thanks very much.